Well, first of all, hopefully people will be streaming in, but we know we're streaming there, so that's good. So first of all, I'm not going to steal any of Jill's thunder, but I'm just so ecstatic and excited about the group on the stage. But let me just kind of quickly back up, which is why we're here. So when Rupa asked myself and Health at WPP to get engaged, it was really more around how do we bring a women's health lens and focus to CAN. And we know there's a lot of opportunity to do that. So we were focusing on the equity piece that Rupa brought up and said, okay, how do we bring up equity? How do we bring up creativity? And how do we accelerate that across her life stages? So we know that in many ways women are gaslit across all those different health stages, and these guys and others are making huge headway in terms of exposing that, talking about that, and really putting the right lens on it. So yesterday we focused on teens and self-esteem and confidence and mental health. We also talked about reproductive health, about how important it is to turn that right side up because women want that. We heard some amazing data and amazing speakers. And now I'm going to turn it over to Jill, who's going to introduce our group who came from all over the world, and we are so grateful to talk about maternal health. This is truly an amazing, amazing leader and group of people. And then after that, we're going to talk a little bit about menopause, which is, when people say it's having a minute, it kind of like gets to me because it should be having an everyday moment, not a minute. And then we're going to close out later today talking about women over 40 and how they are in many ways forgotten and invisible. And I know many women would say, no, that's not true. I feel better now than I've ever felt. But when you look at media and advertising, it is still pretty much the norm. So we'll have someone from Mindshare here to lead that, Nancy Hall. So with that, I'm going to turn it over to Jill and we'll get going.
Thank you so much, Wendy. So I'm Jill Mastroianni. I'm the Managing Director for Health at Gray. We thrive in creating famously effective work. We are at Cannes Lions, which is this amazing place where we get to celebrate this intersectionality between creative and, in our case, health, and the power that creativity has to really solve some of the world's largest, problems in the world. And we have an incredible group of panelists today that I really want to spend time introducing each of them, because not only are they accredited and have accomplished so much, but what they do day in and day out and combining their passion. I had the wonderful opportunity of getting to speak with Leslie, who I'll introduce in a moment right before this, but what they do day in and day out to have real impact, to really push maternal health, newborn health across the world in every corner of this globe, and really try to increase access in education is so important. So I'm going to introduce this group. So first we have Dr. Leslie Mancuso. So Dr. Leslie Mancuso is a business leader and advocate in international development and global health. She is the president and CEO of Jhpiego, an international nonprofit health organization working in 50 countries, affiliated with Johns Hopkins University. Since starting her career as a pediatric nurse, she is now a recognized international business leader with a track record of success in bringing accountability and innovation to the international nonprofit sector. Dr. Mancuso has a long-standing career in leading impactful public and private partnerships with organizations such as the Gates Foundation, GE Foundation, Merck, J&J, Roche, the U.S. Centers for Disease Prevention Control, and many more. Dr. Mancuso was appointed as Jhpiego's president in 2002 and has since grown the organization's budget from $5 million to $400 million and expanded the number of public health programs from 4 to 140. A passionate advocate and leader in global public health, she is the recipient of many prestigious business and professional awards, bringing her expertise to multiple advisory boards and expert panels to advocate and help advance improved health outcomes around the world. Yes. Next, we have Chioma Oduenyi. Chioma is a project director for the U.S. Agency for International Development, Momentum Country and Global Leadership Project in Nigeria. In this role, she leads gender-based violence prevention and response interventions at national and subnational levels, implemented by 6 Nigerian partners in Sokoto and Ebonyi states. She also serves as Director of Gender Equality in Jhpiego's Nigeria office, where she oversees gender integration and mainstreaming across projects. She was instrumental in attracting the World Bank's support of 4 agencies of the federal government of Nigeria to implement a gender-based violence service provider mapping across 10 Nigerian states. Upon joining Jhpiego in April of 2016, she has pioneered gender integration and mainstreaming under the USAID Maternal and Child Survival Program in Nigeria, and she has successfully led policy advocacy to the Federal Ministry of Health to develop the first ever gender and health policy in Nigeria. Prior to joining Jhpiego, Chioma worked and consulted on multiple programs funded by international donors such as the EU, World Bank, Global Fund, and United Nations. She is a public health and gender expert with more than 20 years of experience developing and leading health and social developmental programs and subnational levels in Nigeria and has published extensively. Chioma holds a PhD in Sustainable Development and Diplomacy, a Master in Public Administration and International Development, a Master's of Public Health, and a Bachelor of Science Biochemistry. She is a certified human rights defender of the United Nations Convention on the Elimination of All Forms of Discrimination Against Women and a proud recipient of the 2022 Heroine of Health awarded by Women in Global Health at the sidelines of 2022 World Health Summit in Berlin, Germany. Chioma, Oduenyi. Next, we have Dr. Prabha Chandra. Dr. Prabha Chandra is a maternal health expert with 20 years experience. She is an educator, a researcher, and an advisor on perinatal mental health issues in her native India and internationally. She is a fellow of the Royal College of Psychiatrist, a fellow of the Royal College of Physicians, and a fellow of the Academy of Medical Sciences. A senior professor and dean at the renowned National Institute of Mental Health and Neurosciences in Bangalore, India, Dr. Chandra mentors an enthusiastic team of early career professionals in research and clinical services and started one of the first perinatal inpatient and outpatient psychiatry services in South Asia for mothers with mental illness. She is currently leading the first and largest long-term cohort study in urban India that assesses the impact of maternal mental health on pregnancy and child developmental and behavioral outcomes. She is the president of the International Association of Women's Mental Health and is a member of several national and international organizations and has also served as an advisor to the World Health Organization and UNAIDS. She has nearly 320 publications in the research and has edited 12 books. Dr. Chandra is working to improve maternal morbidity and mortality, including addressing maternal suicide by promoting good perinatal mental health for women in India and globally. She is currently pioneering efforts to integrate mental health into routine, material, and child health in several states in India by introducing case identification algorithms for community health workers in training, primary care physicians in intervention and referrals. Dr. Prabha Chandra. I'm going to hand it over to Leslie to address some of our important topics today. Thank you.
Well, thank you so much, Jill, and thank you for those wonderful introductions. I think we all were amazed with those introductions. Well, good afternoon, everyone. Just so everyone knows, we have a very large audience streaming, so I welcome all of you. We wish you were in the room with us, but we see you through that camera. As the president and CEO of Jhpiego, an international nonprofit that's been focused on improving women's health, I really want to welcome all of you this afternoon. I know that you could have been to many events here at Cannes, but I love that you are here with us for the next 45 minutes. Now, obviously, these issues are very important, but you being here and all of you being online tells me that you too care about the millions of women that right now don't have access to basic health services for their pregnancy, for childbirth, and for after delivering a baby. We say at Jhpiego, where a woman lives should not determine if they live. And that's been very important to us. It drives us every day in our work. For over 50 years, working in 155 countries, we've worked side by side with governments and local partners and health workers to create innovative, low-cost solutions to tackle those toughest problems in women's health and maternal newborn health. Now, since our founding, there's been a lot of progress in maternal newborn health. More women and more babies are surviving and thriving. Yet, still today, despite the progress, today, as I speak to you, 800 women around the world will die due to preventable, they'll die needlessly due to preventable causes in pregnancy and in childbirth. That's more people than the people here at Cannes during this festival. I want you to think about that. 90% of all these women, those 800 a day that are dying, 90% of those don't need to die. We actually have the solutions. That's something that we care about, all of us that are working in the field of maternal newborn health. Now, on top of that, every year 2.4 million infants die before the age of 1 month. So if you think about those deaths, the women, the newborns, often they are in the countries that Jhpiego is currently working in. And you know, I travel all the time, and I have the distinct honor and privilege to be able to see what's happening out in the communities, to learn from health workers, to learn from the government. And I remember so many scenes vividly. One that I remember is going to a rural part of Tanzania. And I went out there to go to a facility that was going to soon bring in all these women that were dying out in the islands because they had no healthcare workers, they had no facilities, and therefore they were bringing them in to have them deliver their babies. So I went to see this facility, and I went into the labor room, and there were 4 women on one mattress, a bare mattress on the floor. And every other woman would lean forward for a period of time, and the other 2 women would lean back. And that is what happened the entire time they were in labor. There were no mosquito nets. There was limited healthcare workers for those women. And I remember that. I remember the health officer and the nurses saying, "Can you help us?" And I thought, we have to do something about this. Women shouldn't be sitting on the floor 4 to a mat. And they shouldn't be doing that without a health worker that's educated and trained. So those visions for me carry me, and that's why we're relentless. We're relentless to say all women should have the ability to have equal health care. And that's what we're going to be talking about today. So I have the distinct honor to be here with Chioma from Nigeria and Prabha from India. And they're going to talk and get into what's behind those statistics I just told you about. And I only told you about a couple of them. But what's happening behind? What are we trying to do to pursue and ensure that women and newborns don't die needlessly, that they don't die from preventable causes? So I'm going to start. My first question for both of you is, we know that India and Nigeria have substantial numbers of maternal deaths each year. And so I kind of want to know from both of you, what's happening in your countries? What's the landscape in your countries? So I'm going to start with Prabha.
Just to give you an idea, we have 1.4 billion people in India. It's a big number. The rates of maternal mortality, mothers were dying a lot 20 years earlier. So we had about 370 odd mothers dying per 100,000. That was really massive and bad and shouldn't have happened. In the last 20 years, interestingly, the numbers come down to almost 97, which is really great. Not great enough, but it's really, you know, a sizable change from the time that women were actually dying in much higher numbers. Let me give you an idea about Bangladesh. In a country like Bangladesh, the numbers are around 157 per 100,000 women who are still dying. mothers, right? So, and we are talking about a 1.4 billion population. 20% of that population are mothers in the reproductive age group, or women in the reproductive age group. So we're looking at potential deaths that can be preventable. And the government has actually been able to do that. So sometimes you think that what has shifted that needle? You know, what has happened in the last 20 years that we are doing better and we are actually becoming a sort of, you know, people that other countries, other low and middle income countries can aspire to achieve. I think one of the important things that has happened is better family planning, better contraception. Women in most of our countries don't have control over their contraception. They don't have autonomy over their reproduction. Reproductive rights are poor. I think just empowering them with good education around family planning and providing cheap and affordable contraception has shifted the needle. Better primary health care. So like you said, where a woman lives should not determine whether she lives or not. So having access to care near your home so that a mom doesn't have to depend on her husband or her father-in-law or someone else to take her out to the health center. She can go herself, you know. That has made the difference. So I think the government with organizations like Jhpiego have actually enhanced the ability for women to access healthcare services. I think the third thing would actually be better information and education to mothers, because I think that's something that, you know, Chioma and I were talking earlier, that information is power. You know, unless you give information to women about what they should eat, their nutrition, why they should have deliveries in the hospital. I mean, a simple thing like having an ambulance to take you to hospital has made a lot of difference. Women did not have trust in the health system. And that is because of a lack of compassionate care within health systems. Like you mentioned, you know, the whole area of obstetric violence, which made women think, why should I go there if I'm not going to be treated properly? I think just working with women, working with midwives, changing the nursing curriculum, helping health workers have more compassionate care where women live has made a sea of difference, and, you know, change the government's policies. So I think the government has realized that there is low-hanging fruit that they can use. I mean, these are not very expensive, but they need that kind of impetus. They need that kind of, you know, push, and to ensure that this is front and center. A mother's mental health is front and center for all the reasons we said. You know, sometimes numbers don't mean much when we say them, we talk about them as statistics, but just to give you an idea, I read just this morning on the flight that in France, one woman dies every 5 days during childbirth and pregnancy. In India, 65 women die every day because of childbirth and pregnancy. I mean, so that's the kind of difference we're talking about, right? And I think 23,000 women die in India because of childbirth and pregnancy. And like you mentioned, that's the population of Cannes when everybody leaves, you know. So I think that's the kind of math that we need to think about. But the good thing is that things are changing, things are improving. We still have a long way to go, but I think we'll get there. Yeah.
You know, you brought up so many points, and I know that you have worked with Jhpiego, and we've worked in areas, some of the areas you mentioned. We helped the government roll out postpartum family planning, an opportunity to help women at a time that perhaps they weren't offered family planning after they delivered a baby. We're helping roll out a new profession, having nurse practitioners with a specialty in midwifery. Again, we're assisting the government. We're assisting our Indian colleagues to roll it out. And at the same, they're rolling out a very big primary healthcare system in India, and we're assisting the government and our local partners to look at what other services can be provided for women at the community level so they don't need to go far, so they can access care maybe for the first time. So you've brought up some wonderful points. Thanks, Prabha. We're coming back, because don't forget, I'm coming back to you. Chioma, you know and I know, but for the audience, Nigeria is the most populous country in Africa. 200 million people. And so what you're going to now, what I want you to talk about is the landscape in Nigeria, because your countries are very different. And they're dealing with some differences, which we must recognize. Every country is unique, and you have to look at the context for each. So talk about Nigeria.
Thank you, Leslie, and good afternoon, everyone. Thank you for joining us again. While I was listening to Prabha, I wish Nigeria's story could even be as a little bit close to India, but no. Nigeria's story around maternal and newborn health is far from what she has just described about India. It may interest you to know that Nigeria has the second estimated maternal deaths globally every year, as well as accounts for newborn deaths, one of the highest in Africa. So our case has been that of stalled progress, despite all the laudable efforts that have been going in over the past decades. In Nigeria, just about 5 years ago, it may interest you to know also that about 80% of married women were still at very high risk of complications of pregnancy and childbirth. In 2023 alone, about 57,000 women died from complications of pregnancy and childbirth. So if you do the maths well, that's about 156 women dying daily. From, like Leslie and Prabha has said, these are deaths that can be preventable. As a matter of fact, 95% of these deaths could be preventable. But unfortunately, we find ourselves where we find ourselves today. The maternal mortality rate is not abating. The neonatal mortality rate is not abating. And that puts us in this stalled progress, and we're trying to see what can change the narrative. So that's the landscape for Nigeria as at today.
And I know I speak, I'm sure, for both of you as a nurse and you as health workers, we know how to solve this. So that's what is so hard, is we know so many solutions that can be addressed. So let's move on to, you've both talked about inequities, but I want to get to more into that because I think that that certainly is something we all talk about around the world, in every country. I want you to talk about, in your context, this, what you see as the drivers that are perpetuating these disparities, and what you think, most importantly, we can do to change that. So Prabha, I'm going to start with you.
Yes, I think I completely agree with you. I think inequity is something that within a country like India, you have sort of the best private care, and you have, you know, women in the tribal areas and in several rural and remote areas without basic care. So you sort of the disparity is so much, and I think that's what touches one's heart as a health professional. That in today's world, you should not be seeing that inequity. Even in urban areas like, you know, Bangalore or Mumbai, where maternal mortality rates are relatively low, you would find women not being able to, you know, get proper care, or the baby dying within the first month, like you mentioned. So what is it which drives these inequities? I think the first thing is poverty, joblessness. I think economic factors, and particularly the pandemic, has really brought that to the fore. I think poverty makes people feel helpless, makes them lose agency. And I think that's something that we really need to figure out a way of, you know, making sure that women have access to universal health, regardless of their income. And I think that's so important. And good quality health. I think that's so important. It's not just health. So to me, poverty is one of the biggest drivers. Along with poverty comes low education. you know, when I go to clinics and start talking to women about their lives and start using like a questionnaire, most women are not able to read or write any of these because they don't have literacy. I think if you don't have literacy, then how do you get health information? So I think we need to think of innovative methods of giving women information, and I think that's another big driver. Nutrition, another huge area which is so preventable, and for nutrition you can't start when a mother becomes pregnant. It has to start when the girl is 13 or 14 or 12 or 11 or 10. So we're talking about a whole life course approach to prevention, which is currently not happening. And I think those are some of the things that I would like to highlight. For example, particularly in states like Madhya Pradesh, for example, where Jhpiego and you know, we have teamed up to work with mothers and the health system there. We're changing the profile of the health system, making them much more sensitive to some of these very preventable issues, where rates of maternal mortality are very high, one of the highest in the country. You know, I was talking about 97, here you're talking about 120, so the highest. So I think, to me, it's poverty, education, lack of information, and basically the inability to access good quality health services, which are probably causing these inequities. Yeah.
I have visited India again this year. I go to different states, and so I've been there before, and I have seen that. I have seen everything you articulate, and I'm glad you mentioned quality, because I think for so many years people were just saying women needed access. But access isn't the only thing. They need quality care when they get access to care. And that's a big difference that we're all talking about now. Excellent. Chioma, what can you add to this?
Okay, thank you again. So, so for us, similarly, like in India, we also have this large socioeconomic inequities. These socioeconomic inequities limit women from accessing health when they want it. So in Nigeria, we have a catastrophic household health expenditure. And this means that out-of-pocket payment for health services accounts for over 77% of the total health expenditure in Nigeria. So that means that only rich and wealthy Nigerians can access health, you know, when they need it. The poor Nigerians will continue to lag behind, and they are not able to access this help because you have to pay out of pocket. So as she mentioned, poverty is a huge cost, is part of the inequities that stop women from accessing this care. Then we also have geographical inequities. We have women from urban areas being able to access maternal health services, whereas women in rural areas are not able to do the same. In Nigeria, specifically, we have women in the southern part of Nigeria able to access, you know, utilize maternal health services more than their counterparts in the northern part of Nigeria. There are also several other inequities that happen. When you look at sociocultural norms, gender inequities, that looks at gender roles, gender stereotypes that restrict women's mobility. So those are part of the things that impact on women's health-seeking attitudes. Then you look at some structural issues around accessibility to health facilities, where there are impassable roads, transportation is high cost of transportation. So some of these poor women would rather stay back at home and give birth, you know, when you don't have money for transport. Then when they eventually find themselves at the health facilities, some health facilities lack basic amenities. They don't even have clean running water, electricity. So the health provider is there, ready to provide the care, but the structural inequities is stopping that woman from accessing this. So there is a huge lack of access due to several inequities. So, however, you know, I think you just mentioned quality of care. So quality of care Jhpiego understands that this is the most critical thing, to focus on. And that is what Jhpiego has been doing over the years in Nigeria and around the world. We have continued to channel a lot of resources in building the skills of health workers. And these health workers cut across different cadres of health workers. Nurses, midwives, community health extension workers. Jhpiego in Nigeria has partnered with government at all levels to provide competency-based skill training for health workers, and this has helped them to improve in the quality of services that they provide. Just imagine within the, these settings that I described previously, these health workers are still able to provide some of these services because of the training and mentorship and supportive supervision that they have received from Jhpiego. Over the years in Nigeria, Jhpiego has partnered with governments at all levels, like I said. We do a lot of training because we recognize also that when you have skilled nurses and midwives, they are able to manage complications of pregnancy and childbirth. But when there is no training, there is a challenge. So we've been able to build a crop of trainers. So these midwives, nurses, they go back and train their colleagues. We also come to their facilities to support them with this on-site training that also provides like supportive supervision. So these midwives, nurses, community health extension workers, they're able to provide this care. But in cases where the women now need higher care, we also support them with building referral pathways. For instance, when there is need for cesarean section, they're able to connect with higher facilities. But largely, we know that midwives are able to support women through that continuum of care. Yeah, I think there is one other inequity that I missed out. For instance, in Nigeria, we have just about 1,000 OBGYNs compared to a similar country like Brazil. Brazil has almost similar population with Nigeria. In Brazil, you have 37,000 OBGYN. So imagine that. So this is part of the global inequities that you find in maternal health. So let me stop there.
I'm actually so glad you said that, because I wanted to talk to you about the fact that why are we talking about nurses and midwives? We know worldwide they provide 80% of care. So if we're going to look at inequities, we have to address ensuring that they have the skills, the knowledge, the support. That's not to say we also work with community health workers, with OBGYNs and the like, but there's a reason why in Nigeria and many other countries we're focusing on the nurses and midwives. Now, both of you I see as pioneers. You probably haven't been called that before, but I'm going to call you that now. And I hope everybody calls you that moving forward. Because you're both working in really critical areas that impact inequity. Chioma, you have done groundbreaking work, in preventing and addressing gender-based violence, not only in Nigeria, but worldwide. You are a spokesperson for that, as was talked about in the introduction. Prabha, you have tackled a topic, perinatal care and perinatal mental health, as a really important topic. You not only are a global leader in this area, but you also facilitated the establishment of a new model of care in Bangalore around perinatal mental health. So I want you each to talk about those initiatives and how those initiatives are helping improve the lives of those mothers, those families, those communities. Again, let's start with Prabha.
Thank you, Leslie. Pet topic. So, soon after I got trained in psychiatry, I met mothers who would travel. So, for example, the first mum I saw was a young mother, 20 years old, with a 2-week baby, with very severe depression. And she had gone to multiple faith healers, temples, branded, came with severe nutritional deficiencies and highly suicidal and completely psychotic. And we didn't have a facility to care for her with her baby. And she wanted her baby to be there because it was very important for her. And that got me thinking. I said, this cannot happen. This cannot happen. And so I went and got trained in some of the best centers in the world, in the UK, basically, and in Australia, and said, I want to go back and do something similar, but with some differences, because there has to be a cultural sort of angle to it. It has to be different. So I went back. I trained a whole big lot of mental health professionals in the specialty of perinatal mental health. Nobody was talking about it. I made them understand how anxiety and depression in pregnancy can have a huge impact on the mother and the child in terms of even long-term developments, things that are being talked about in research today, you know. We then set up a wonderful service, an inpatient service and a dedicated outpatient service, which gets referrals from all over the country, both virtual as well as in person. And we've developed a model where grandmothers provide the support to the mom and the baby. So most Western facilities would actually just have the mom, and a nursery nurse would provide care for the baby. And in India, you would never see a family leaving a mom and baby by themselves. There's no question. So the grandmothers become our support system over there. And it's a wonderful facility. It's a wonderful space where women with mental health problems with their babies get nurtured by their families. And then we started a community service related to that. So that's like a model, and it serves as a beacon of hope to other low middle income countries, that everything does not have to be terribly expensive. You can develop local models with some resources, but much more important is training. And the fact that they can get care with dignity and in a non-stigmatizing environment. I think that's what women want. The fact that this place is lovely and has a little garden and everything makes them feel respected, even when they're dealing with really bad demons in their head. In pregnancy or in the postpartum period. And then we said, this is not enough, it's a local service, we need to sort of expand. So we started training midwives, nurses, doctors, obstetricians, developed a platform where anybody can talk to us through a helpline, through email. Families, mums, husbands can call us up and get information, or write to us and get information anytime about where to access care. We developed a network of perinatal mental health professionals in the country, you know. But then we decided that's not enough. Let's go further. And so now we're really excited that finally the government in many states, including in Madhya Pradesh, has decided to include 3 questions. And we bargained and bargained and bargained, because if you look at a mother and child health card, it has 50 questions in it. And to even get 1 question on anything in, you have to talk to the policymakers. And so we did a lot of advocacy, and they said, we are printing the cards tomorrow, give us 3 questions. And we got those 3 questions in. And why is it important to get those questions on mental health in? It's because you get data. That's right. And once you get data, you get evidence, and you can then, you know, advocate for more services. And now we are working in 4 states, and more states are coming forward. So in India, health is a state subject. So each state has to, and they're now competing with each other, saying we want to integrate mental health into routine maternal and infant care. And I think, to me, that's a real success. We've also started using technology quite a bit, because if you look at clinics in India, they are high volume. You know, you have 200 and 300 moms coming in every day. That poor nurse, by the time she finishes talking to them, taking their weight, and just doing the basic stuff, she doesn't have the energy to talk about mental health. And she doesn't want to open up a box saying, oh, they'll start talking about mental health, what will I give them? So we're trying to use technology through films, through self-rating, using audio for low literacy, kiosks where they can talk about their mental health using smileys, emojis, and using creative methods which make the woman feel engaged in her own care and help the health workers actually provide that service. Women are now able to trust, because talking about mental health is not easy for anybody. And unless you trust a health professional. So we're amazed at how beautifully the nurses are able to actually engage on mental health. Some of them don't even ask them the questions. They look at the face of the woman and say, I think she's got a problem. And I think we need to engage with her at a different level or whatever. So I think these are the innovations, and I'm really hopeful that, I'm very optimistic right now about this.
So am I. There is no doubt that we know worldwide that there are women confronted with mental health issues during pregnancy and after. We have health workers confronted with mental health issues, and it's all a neglected area. And I see your work as pioneering work. You're a global expert, and the importance is bringing and looking at models that can be brought to all countries, particularly low resource countries, because what you've done is created a model that is not burdensome from a cost standpoint, but has a model to it. So it's a neglected area. It needs to be addressed, and I love what you're doing. That's why I called you a pioneer. Now I'm going to my second pioneer from Nigeria, who's going to talk about all her work in gender-based violence. Not all your work, because we don't have that much time, but just highlights.
Yeah, thank you again, Leslie.
Yes.
And just like mental health, gender-based violence is also another neglected area. For many societies that are patriarchal, you will agree with me that gender-based violence is real, and it has become a growing public health concern. This morning I was asking Prabha, what's the burden of gender-based violence in India? And she said, it's high. Like, it's high in my country. It's high many places around the world. And we also know some of the things that are fueling GBV. The culture of silence, gender inequalities, these are all drivers of gender-based violence. We're very privileged to have USAID fund us in Nigeria, that's Jhpiego, to lead a project that specifically works to prevent and mitigate violence against women and girls, addressing drivers of child early and forced marriage, and promoting early adoption of family planning. So through this project, we were able to engage with the whole spectrum of the society, from the individual unit to the family, to relationships, to the society at large. We engaged with very young adolescents. We decided to catch them young, as the phrase goes. We engaged very young adolescents to be part of sessions that talked about gender equitable relationships, attitudes, behaviors. These very young adolescents, we also engage with their parents, because all of those gender norms, issues that drive gender inequality start from our families. So through this project, these cohorts of young boys and girls were taught, gender equitable attitude in places where boys were not allowed to support girls, prior to the project. We saw a lot of changes. Parents were supporting their boys and girls to share roles at home. Then we also engaged with the parents. So many of these parents didn't know that it wasn't good to give out your child so early in marriage, because those are part of their cultural beliefs. But when this information came, again, information is power. When we brought this project, we saw that many betrothed girls for marriages were stopped, because the parents learned through the session that it would be better for them to allow these girls to finish secondary school. We saw even the girls themselves who have been dropped out of school, wanting to go back to school, and through the project, we were able to reinstate some. So this was supposed to be a health project, but we saw the project helping to reinstate girls back to school. and even boys. So we also engage with the entire community, talking about gender issues to break the culture of silence around gender-based violence. So imagine in a culture where men and women cannot talk openly about GBV, it's a private affair that, like we hear all the time, we created safe spaces for them to talk about it. It's also important to note in this topic of maternal health that we're talking about, that evidence has it that women who suffer gender-based violence get it exacerbated while they are pregnant.
That's right.
So that means the cases of intimate partner violence increases when a woman is pregnant. So imagine the consequences of intimate partner violence on a pregnant woman, on the unborn child, and what have you. So we also initiated some couples communication activities that helped couples to talk to themselves, bring back communication, trust, and love. We saw a lot of men, expressing what they have learned being part of those sessions. So we also engage women themselves. So part of what fuels some of this violence, poverty is also part of it. Like we were saying, if there is no food at home, the man looks for who to pounce on. So the closest person may be the wife. So because of that, we introduced Women's Empowerment Program. And that was targeted at helping women build financial empowerment as well as economic empowerment through community savings and loans groups. So these women, they come together, they're able to start up savings, and they use the money that they borrow themselves, each other money, and they start up businesses. And by that builds their agency to be able to fend for themselves and reduce incidences of intimate partner violence. So overall, in addressing gender-based violence, Jhpiego has led a very successful campaign in Nigeria through this project. And we've been able to support government as well to develop gender-based violence action plans. Before now, even the government officials didn't know what exactly to be doing. So addressing GBV in the health setting, we've supported governments to also develop guidelines at the health clinics. Providers are also trained to be able to identify cases of GBV through routine screening when clients come to health centers. So having done all of this, I can say that the culture of silence around GBV in these settings where we work, it was very surprising to see that it can easily be broken. So we should all speak up. Thank you.
I was with Chioma in Nigeria not that long ago. It seems like not that long ago. It might have been a couple months ago. And went out to Boni State, where we're doing a lot of work. And I remember going to that community, very far out. And the village lay leader spoke in his own language, but talked about how he didn't see any need for any help with gender. Didn't see any need. They were fine. And he talked about saying, when they first came, he said, I didn't see any need. I thought we're doing perfect. And it wasn't until that dialogue started to take place in that village, and they started to look at what was happening, and he said, now I understand. We have changed. We have changed how we work together. We have changed how women are part of our community. It was fascinating. I think the other in that visit was watching the governor of a Boni State at a major event stand up and talk about gender-based violence and talk about that we needed to address it. And he was going to focus on this and continue to focus on this. It was a silent topic for so long. Now, I know we have 5 minutes, but I'm going to get to, well, she's saying 3. We're going to keep going. Because, there's always time, right? Okay, so now the last question I want to ask you is, if you know me, I'm about hope. I'm about what's next. We can do this. We have, So what gives each of you hope? What gives you hope that we will solve where a woman lives does not determine if they live? Prabha. And they say 3 minutes.
I was reading an article which has a very nice title. It said, "If you listen to whispers, you can prevent the screams." And I think to me that's very important. Listen to the whispers, which basically means listen to all the evidence that's coming up. Right. You know that anemia, nutrition, the fact that access to healthcare, planning of pregnancies. And women having the agencies to decide when they want to have babies, couples thinking together before they become parents. Right. These are things that we know are currently threats. We know what the barriers are. Right. We know why women don't come to health systems, right. How to enhance trust, right. How to provide compassionate care. So we know all the repair. Right. We know how to repair these vulnerabilities. To me, it appears that the time is ripe. Policymakers are also engaging a lot. I mean, I had one person, a very senior bureaucrat, saying he wants to be part of a paper, which we have just written on this topic, and said, I want to be a co-author. Right. To me, that's great. Fabulous. A person who wants to write, a policymaker who wants to be part of a perinatal mental health paper means he will be a voice in all decision making, in all funding. So this gives me hope. Yeah.
I have hope. I love that. Chioma, what gives you hope? How are we going to reach this? That women aren't getting different care around this disparity is going to go away.
Thank you. So again, let me talk about hope with Nigeria. Nigeria just got new government in place. Yes, last year. Because somebody will be wondering, Nigeria should be a rich country. Why all of this? So now, currently, the government is trying to revitalize the health sector. So they are mobilizing resources from stakeholders, from everyone. The health minister is out there mobilizing, advocating for everyone to join hands to support Nigeria. Because if we change the narrative in Nigeria, it will impact the world. But most importantly, the work that Jhpiego does. Mm-hmm. Because Jhpiego helps governments in Nigeria to ensure that health workers' skills are built. That is critical. So if we can continue to do this work that we do, then we are sure that the quality of services that women will receive at healthcare facilities is guaranteed. Mm-hmm. Then, of course, our government is trying to mobilize resources to ensure access to universal health coverage, right. Which is a big topic, focusing on primary health care. Right. All of that points us that there is hope, but we need more support. We need more support technically, financially, everyone putting hands together, and we can change the narrative. So with the work that I go back to Nigeria and continue to do under Jhpiego's platform, I am very hopeful. As government is also bringing and leading campaign on ground, I am very hopeful. So thank you.
I think your important point is when you have that government finds itself on the leadership level, they're leading and have that as their goals and their decision making, that makes a difference. And I think that's a very important point in that story. So I know we're at the time, but can I take one question? Okay. Okay. So I want to see if, I know we have many people online. I wanted to see if anybody here had a question for either one of the speakers today. I know someone has to have a question for Chioma or Prabha. Anyone? A thought, a comment? Please, I see it. And then I'll get Wendy. Please. If you could stand up just so we can see you. Prabha, Chioma.
Thank you, first of all, for even asking that question, because I think it's very thoughtful and very important. Like we just mentioned, there's a lot of areas that we need to focus on. Information needs are very, very critical. And I think people who are creative can actually bring in, I was looking at the daily news when I was sitting out there of this meeting, and I saw so many interesting ways in which you can communicate with communities, with people about various aspects. So maybe maternal health is one area, including mental health, nutrition, gender-based violence, where we need to find methods which touch the heart, which will make a difference to behavior. And I think that's where we would definitely, I would welcome inputs. Educational material, you know, how do you improve pedagogy? How do you improve the, you know, compassion amongst health workers when they see women is again another thing that needs a little bit of a different way of out of the box thinking. And of course, funding is always welcome.
Chioma.
Okay, so thank you for that very thoughtful question. We have a lot of costed activities in Nigeria, but you know, with little money to fund some of these activities. You know, it's a big place. No matter how little, $10, $100 can make a difference in the life of a woman and her baby and her family. So how can you help? Any way that we can get money to add on to what we're doing to reach more people, that is welcome. Thank you very much.
I think as women, and there's a lot of women and men in this audience, and I love to see the men. Someone said to me, you know, Leslie, when you're out there, you know, is it just women that care about the issues? And I said, no. I've had men that have been at talks coming to me and saying, you know, my wife delivered in New York City and overlooking the Hudson. And then I'm hearing about these women on a mat in Tanzania. And so I care. I care. I have a wife, or I have a mother, you know, they all have mothers. And so I think this is an issue for all of us. And I'd like to say it should be an issue that we all should be adamant. In this day and age, 800 women died today that don't need to die. Let's say 95%, 90% don't need to die. We should be adamant. This is not acceptable in the countries, in the world in which we live in, that women die like that. So I thank you for that question. Any ideas you have? We're probably always not the best at, we can talk about it, we can talk about our programs, but you all are these creative minds that can take those granules of information and say, you know what? We can help figure out how you tell that, because that's probably not what's the strength of groups like ours. So I thank you all for being here. Wendy, you wanted to say something. And can I tell how you relate to it? Yeah, Wendy is one of our board members. And let me just say, she just came on board this year. You know, we have board members that are volunteers. She's a volunteer. She gives her time to Jhpiego. So I just, you know, I want to thank her for this.
It's my pleasure. So before you leave the stage, I think I can say on behalf of everyone in this room, thank you, thank you, thank you. You asked about hope. You guys give the world hope for what you're doing. I mean, it's amazing. And I always say that nurses make life go on. Leslie, you are the person in this world who probably makes more life go on than people even know. So I just want to specifically say thank you. So before I get choked up and start to cry, I just want to say that creative minds in the room, challenge taken. And that's why they're here today, to challenge all of you to think differently and help them think differently, and look forward to the next time. Thank you.